So let me introduce the panel. I believe all of you have your formal sheets, but now that you see them in person, Dr. Ron DePinho, who is the president at the University of Texas MD Anderson Cancer Center, world-renowned. And to my right, fellow Asia Society trustee, Omar Ishrak, the chairman and CEO of Medtronic. So let's begin first with Ron. And we're going to begin with one of the big questions, which is, Ron, would you talk a bit about what it means at this moment in history to be a human being in our universe and what you are seeing in science?
Well, it's a very provocative question, and I'll give a very provocative answer. First of all, it's an honor to be on the same stage with both of you. Well, if we just take a step back, let's say, look at our period of human history millennia from now, it's going to go down as a major turning point for who we are as a species. And so a seminal event occurred in 1953 when Watson and Crick discovered the structure of DNA, and that then led to what is now the genetic basis of life, an understanding of it, and an understanding of those genetic elements that actually govern biological processes. Do we know everything? No. But what we have is we have a framework for understanding life on such an elemental level and understanding the basis of disease, and increasingly so, to such an extent that for the first time in who we are, we're not simply changing the way that our environment interacts with us, or perhaps curing infectious diseases, the assault that we're constantly under from the environment, be it microbes or pollution and so on. And we're trying to, with water hygiene and antibiotics and vaccines, changing the human condition. We're now pivoting to a point where we can ask the question of the fundamental circuits that govern who we are, how information is stored in the central nervous system, how our body decays. Are we actually in a position for the first time as a species to actually control what it is to be human? And to use that knowledge in a way to extend life, to extend the experience, to expand our knowledge and capabilities in a way that's enhanced by the very nature of how those processes work. So there.
All right, that is indeed provocative. So just in thinking about enhancing our lives, the human body, we could be 200 years old, but we might not have a memory. Is that?
Right, so I think so there's life expectancy, and then there's lifespan. So lifespan is fairly hardwired into species. So a mouse under pristine conditions can live 3 years. Hard to imagine we could get a mouse to live 100 years. Why? Because the inherent metabolic rate of the cellular processes there are such that you basically burn the candle down. Right? So you can regulate the rate of burn, and it is possible, based on knowledge we have today, to genetically engineer a mouse that live 50% longer. So you actually can increase the lifespan, but quantum leaps is very, very difficult. What we need to really think in terms of is health span, not lifespan. And that relates to a comment that I made before, which is after the age of 60, you have every 5 years a doubling of the incidence of Alzheimer's, diabetes, heart disease, and cancer. By the time you're 85, you have a 45% chance of having Alzheimer's. And so the question is, can you push that curve towards the right so that you can expand the quality of life and the robustness of the individual, and then within a very narrow window of time, have the processes that govern the aging, the circuitry of aging that precipitates cellular senescence, have those then take hold and get into this feed-forward rapid decline that we see in aged individuals that have been free of disease, but within a narrow window, eventually move on and succumb. And so that, for us, is, I think, the greatest opportunity for us in terms of being able to know what we know now about disease and its basis and the aging process itself, and try to just push that towards a later point so that we don't incur the burden and have these diseases extend over a very significant period of time.
Mm-hmm. Which indeed goes to the point you made in the last panel about what would be the impact in China and Japan and many of the Asian countries due to their demographics. In the United States and in many countries around the world, cancer has been a major issue. And how to deal with cancer, the science of cancer, what you are finding in the laboratories. Would you talk to us a bit about the Moonshot?
Well, the Moonshot idea, the concept was, and that all fields reach a point in time where you actually have a critical mass of understanding or technological prowess that gives you a line of sight to say, are we just going to do the next experiment or the next minor advance? Are we at a different point in the history of the field? And can we organize ourselves in a way that's far more goal-oriented? So you think Manhattan Project, it was a clear goal. The Moonshot, clear goal. The Genome Project that President Bush launched in 1989, very clear goal. And what it took was first articulating a goal as opposed to the next step. It meant finding the right multidisciplinary teams to come together. Think the atomic bomb, you needed theoretical physicists plus material scientists plus bomb makers. You know, Einstein alone would not have been able to do it, right? And all you need, so you need that confederation of transdisciplinary activities. You need to support innovation, and you need to support those, kind of cross-discipline activities. And you have to properly resource it. We spent an enormous amount of our GDP on the Moonshot. It was a real national commitment, and we got it done. And so with that mentality in mind, in 2009, 2010, I think we underwent what is nothing short of a major turning point in the history of science. This, I think, never occurred before. Within a very narrow window of time, there was a confluence of technological advances that occurred in the ability to sequence genes in hours for a few $100s, what took $1 billion in a decade not too long ago, where you have advances, true cognitive computing, true artificial intelligence for the first time, the ability to handle large volumes of data, manipulate it, analyze it, the ability to genetically engineer mice with exactly the same mutation. So all of these major, major technological advances across a broad front occurred. At the same time, our knowledge of cancer had advanced. And we had a pretty good understanding of the rogue genes that are resident in various types of cancers, thanks to the Genome Project, which started in 2007. So we now have a periodic table for cancer. One of the most exciting advances is we now understand better how the immune system works. It's curious that cancer, which should be recognized as foreign, is stealth to the immune system. Why is that? Well, Jim Allison in the 1990s asked the question, and he discovered a brake on the immune system that's engaged by cancer, developed a drug against that brake, cut the brake line, so to speak, reawaken the immune system, and we're seeing a very large fraction of certain cancers now being cured of the disease, of their disease. So not just prolonged, but eradicated, 10 years out, advanced disease. And so you have the technology, you have this conceptual maturity, and the question is, are there ideas that we have, knowledge today, that if simply prosecuted would lead to a reduction in cancer mortality? And the answer is unequivocally yes. And so we know, for example, that, and some of these are not necessarily diagnostic advances, as I'm sure we'll hear about, or therapeutic advances, as I just mentioned. Some of these are policy or educational commitments that we have to make. Our children are very vulnerable to sun. So tanning beds is a huge issue. That's a carcinogen. 11 tanning bed episodes under the age of 20 increases melanoma by 85%. One childhood sunburn doubles your rate of melanoma. How many people had a skin peeling sunburn during their childhood? Okay, I myself as well, multiple, right? So there's a vulnerable period of your melanocytes, so you should be make sure you get a dermatologist screen every year. The key thing is that simple knowledge is not translated into K through 12 education, as we did with traffic safety and seatbelts in the 1950s on up, which led to a cultural change. It doesn't lead to laws that protect children under the age of 18 from getting tanning bed and so on. So that knowledge has been around for a while. But in the context of the moonshots, what we did is we said, we want to have a goal, clear articulated goal. Okay, in melanoma, we want to have every state in the United States have tanning bed legislation. And we're well on our way to doing that. Texas was the 4th state in the country to enact such legislation. I'm very proud of our legislators. We worked with 8 other states. Colorado now has just signed into law. So this was knowledge, but we didn't act on it. Why? Because we just didn't organize ourselves and say, we're going to go to the moon. You know, we're going to go to a destination. We have a goal. And we're going to figure out how to get there. You can't get there with just academic scholars. You have to get there with people who have knowledge in legislative affairs, who have knowledge in K through 12 education, who have knowledge in media. These people have to come together with the scholars. It's that transdisciplinary activity, that goal. And it has to be properly resourced. This is costing us millions of dollars at MD Anderson that we're fueling with philanthropy and other kinds of activities, CPRIT and so on. So I think the field technologically, conceptually has reached a point. What we've done is we went through the exercise, were it not for resources, were it not for technological access, were it not for being able to work with the right playmates to get something done. If we had all that eliminated, we assembled those activities, we enabled those activities, what would that make an impact on cancers A, B, C, and D? We went through that exercise. We identified 8 cancers for which we felt there was actionable information today that if prosecuted, we would be able to reduce cancer mortality. And in some cases, I think we underestimated our success. In other cases, we may fall short. But at least we tried.
Well, exceptional, revolutionary, exciting. I mean, this would change the ability for people to have those long, healthy lifespans that we would wish them to have. And certainly cancer and being able to organize ourselves for a moonshot would be exceptional. Omar, then let's pick up with your thoughts. You have been leading a company that is known for its technology, its diagnostics, but you also think about healthcare systems and doctors and patients. Would you talk a little bit about how you view the world that Dr. DePinho has just described?
Yeah, let me just kind of start the conversation at the point where Dr. DePinho perhaps left it in 2 counts. First of all, the point about extending when effectively aging starts, which I think, as was described, lots of progress has been made and lots of opportunities exist through big programs. But equally, what I've gotten to learn over the past few years is that beyond the point where physiologically aging can be extended, the point of aging can be extended, you have other technologies through which life can then be extended through artificial sort of implant means. And that's a whole new dimension of life extension that can be added after the point in which the body starts to degenerate naturally. So, you know, the vision of life extension may be even longer than what you define as lifespan, simply by having, you know, virtually electronic components or mechanical or very advanced components that go inside the body that extend life. You know, the simplest example that I can give you, which is perhaps most compelling, is, and there are many, but the one that I think takes it to the limit is I'll take a disease like type 1 diabetes. There, the aging process kind of, if you like, in that model, has started very early because of this failure of the immune system, I guess. Even at a very early age, a person, you know, 100 years ago would probably die because the body doesn't generate insulin anymore. And so that's a place where aging has happened when you're, you know, 10 years old. And yet, there are ways in which you can extend life, not through crude means of injecting insulin manually, but we can see a day within the next, I'd say, 5 years, when you will get what we call an artificial pancreas which is totally, which is a combination of a pump and a sensor, all controlled automatically, that will make type 1 diabetics' life almost completely normal. And so that's an example where, I've shown an accelerated case where the aging has happened, if you like, if I'm just using that as an analogy, and the electronics or the implant, or the artificial means have been put in place. Now imagine that across a whole series of diseases. In cardiology, I think cancer, there's a lot more learning to happen, as we just heard. In neurology, all over the human body, there's a propensity of diseases. Some are well understood, or better understood, where the aging process is sort of mapped out, and where we're beginning to put these electronic means in, or artificial means in. And through that, I'd really like to paint a very optimistic vision of the future where life extension can, into the next 100 years, can be a goal that I think is worthy of being a big goal. I mean, I'm not saying by a factor of 10, but certainly by a factor of 2, and this is a personal opinion. Within the next 100 years, I don't know if if that's completely impossible. But I don't know. I mean, this is just a complete conjecture on my part. That's one piece of it. I think the other piece which you were getting to, Henrietta, which I can perhaps take on a little later, is while all this is true, I think the projected benefit of healthcare versus the realized benefit of healthcare, there's a huge gap. There's a huge gap. And that's what causes it. If all this was true, and people were living longer and living better, then why is healthcare spending a problem? Because all of this should generate more growth in the economy. It should lower costs of care, because if you are better, your cost of care is lower. And yet we have at least a perceived problem of healthcare spending. So I think that's a whole different issue of innovation that needs to be tackled.
Well, this will be very exciting if we can be partially bionic, and it also might help in terms of our healthcare costs, but who knows? Ron, did you want to jump in on that?
Actually, so this was really, just to add a dimension to this excellent comment, the whole interface between bioengineering and our existence, I think even less so than, let's say, even tissue engineering and implantation and stents and all sorts of things that are really enhancing our ability to create bone and do all sorts of things, incredibly exciting. And that will extend the quality of life, no question, and perhaps the quantity of life. What's particularly exciting, and I think is going to be transformational within the next decade for sure, is that most of the diseases that we have are preventable or can be detected much earlier, or if they're even known, to be managed much more effectively. So even the simple ability to, we're both wearing devices. I have my Fit Force, and you have Jawbone. Is that? Yeah, there you go. So the interesting thing is that we have the ability with some of the great technology that's being developed by one of the best companies in the world, and other innovators like Google and so on. Google has a contact lens that can monitor glucose in real time. So imagine if you're diabetic and you're feeding information like that real time into your phone, and you could really know whether or not you're in glucose homeostasis, or if you have hypertension, and you're able to monitor that in real time, so on and so forth. And so the lowest of the low-hanging fruit is prevention of disease. So 50% of cancers can be prevented. 50%. And I can go through what that is.
It's a remarkable statistic.
But if you also were to detect cancer early, you would have a dramatic decrease in mortality and a dramatic decrease in cost. So while we talk about the expanding cost and burden, the reality is that what we need to be focusing on is not getting the disease in the first place. If it does occur, catch it early. Once it is entrenched, monitor it and manage it very effectively. Everybody's on their devices right now because they're bored with my comments, but just even sub-Saharan Africa has iPhones now. Everybody has iPhones. there's no reason why we can't use this connectivity that has a revolution of connectivity that's gone on in the world, and the ability with relative ease to be able to monitor health in real time in a way that's going to allow us to be far more preemptive and interventive in how we detect and manage disease.
Mm-hmm. Then, Omar, let's go back to something that you began to presage, which is, in the last panel we talked about emerging markets, and you have been working in countries all over the world. Will you talk a bit about the health challenges of the entire developing world, the emerging markets, and then we will turn to you, the audience, for questions.
Omar. Sure. With emerging markets, the way I see it, of the three core problems in healthcare, which I think people generally acknowledge, one is to improve the quality of care, which we've talked a lot about. Second is to lower the cost, which goes along with improvement of quality, but also efficiency. And the third is access. And I think, if you like, in crude terms, in the developed world, quality and cost are the main focal points and should be the focal points of healthcare. In the emerging markets, it's access. And that's why I think today, all over the emerging markets, there's a rush, if you like, to provide access by governments because of a whole variety of reasons, from political to just social need, to provide access at different levels. When you think about the level of access that's available in some of these markets, some of these people, it's numbing. The fact that literally billions of people in the world don't have access to treatments that were invented 50, 60, 70 years ago is just untenable. I mean, it's tough to believe that actually happens, that the gap is so big that in a developed country, an individual can do something that they can afford and extend their life by 10, 20, 30 years, while a person in an emerging market with the same disease just takes it for granted that they'll die, that's how long life is. And that gap needs to be addressed and will be addressed. And I think technology can play a major role in that. I think a lot has been said in this regard. In my view, for the underserved, we need to draw balance between creating infrastructure and picking diseases and generating ecosystems within the diseases to move the needle of care in those areas. In other words, pick maternal infant care or pick infant mortality. And those are very specific goals, which have very specific ecosystems and specific infrastructure that can be built, that can move the needle, as opposed to building millions of primary care centers, which is important, but isn't necessarily going to move the needle unless the disease-based look is completely tied. And so I think that's where I think there's a lot of interest there. The governments want to invest there. If you want to think of spending, China, for example, spends less than 5% of GDP in healthcare, compared to 17 in the US, which may be too high, but still the gap is huge. India spends less than 3. And these are two countries where alone you have probably several hundred million people on the high side of that who don't have access to care. So governments have to kind of drive in that dimension, and I think that's really necessary for their growth.
Yes, and the lack of implementing many of those solutions is just heartbreaking when you travel the emerging economies in developing countries. All right, audience? Yes, please.
I have a comment and a question. First of all, Dr. Pinheiro, I would like to thank you, the doctors and nurses and your staff at MD Anderson, for your courage, your compassion, for what you do every day dealing with these horrible, horrible diseases, and I wish you all the best in the future.
Thank you.
And this is to the panel. As we're standing here in the Asia Society, I look back and there's wonderful, I believe, medicines out there, Ayurvedic and traditional Chinese medicine, acupuncture. My question to both of you gentlemen is, are you looking at those technologies that have existed for thousands of years, that have produced wonderful results, and attempting to bring them into the modern world. Thank you.
I could start and you could.
All
So
right.
MD Anderson embraces this. We've been humbled by our ignorance, as a field, and we look for opportunities wherever they may lie. And in fact, we have an alternative medicine program led by Lorenzo Cohen that has focused on this space. And some of the great medicines that have come out, like arsenic, transretinoic acid, they were really discovered in the context of China. And there are significant efforts underway to look for what ingredients in various alternative medicines really have the active components that are apparently giving results. The challenge in that space is that the science, the controlled experiments, have not been done always with the same level of rigor, and there's a lot of misinformation and so on. There are more surprises than fulfilled prophecies in science, so you have to really rigorously test whether or not something is creating benefit and so on. We have these religious intuitive views of how something would work. Take vitamin E, right? We extrapolate antioxidants, if you eat your blueberries and pomegranate juice and so on, that actually has been shown in controlled clinical settings to actually have an impact on reducing cancer. And pomegranate juice, which is probably the most powerful antioxidant, reduces prostate cancer. However, vitamin E, so something artificial taken out of context, actually increases the incidence of prostate cancer. So you need to do the controlled experiments to know whether or not something is really going to provide the benefit and will do no harm and will also be of value to the patient, cost-wise as well as benefit-wise. So we need to carefully look at that. With respect to meditation, acupuncture, all of those things, they have clearly been shown to be beneficial, again, if applied properly to a variety of different settings, particularly with respect to cancer.
I think actually, adding on to all the comments that were made, what we've found, or at least I've personally found as I've sort of gained experience around the world, is that China probably has the most structured system of alternative medicine. I don't know if it's well known here or not, but in Chinese hospitals, there are actually two departments which are viewed equally. One of traditional medicine, Chinese medicine, one of Western medicine, and that's what they call it. And there are a full program and a hierarchy of doctors and so on who are trained in the traditional medicine way. And so I think if one were to start to cross that bridge between our Western medicine and traditional medicine, I think China is a very good place for companies and other institutions to go and learn from. I do think, though, that the point about the lack of rigor in data in traditional medicine is true, and therefore, although a lot of hypotheses may exist, hard data really doesn't exist, even in that structured way in China, because I don't think they did clinical trials or anything like that in a rigorous enough way as they built up the hierarchy of delivery. But it's something I think we should do, and this is fraught with danger and false hopes because things like placebo effect. I mean, there's all kinds of other things that go on, which we find in Western medicine that high hopes can sometimes be dashed because of a whole variety of reasons. And again, just because there are anecdotes may be too narrow a term, but just because there's a familiarity and a history and experience of benefit doesn't really mean that it's clinically proven or data-based, or it may well be there's something there in a very narrow segment of population, while in fact it's generalized. And so getting that down to science is a task, but it's something that as a society, it behooves us to take that on, because there's rich experience there. And for us to waste that, I think, is wrong. And I'd start with China because of the structure that they built.
Thank you, Omar. I see one question here, one question up here, and was there one more down here? So we'll take two questions and then close. Please,
Yes. First of all, I want, as a cancer survivor and MD Anderson patient, I want to thank you for sure. You mentioned the fact that there could be in the next 5 years a synthetic pancreas. I'm just curious as to how that might impact pancreatic cancer, since the high mortality rate of that, if there is any connection at all to what that might be able to do.
Well, the artificial pancreas component that was referred to earlier is the endocrine component that regulates the hormones like insulin and so on. There's another component to your pancreas, which is the digestive part that secretes enzymes that allow you to digest your food. That's the part of the organ that has significant, where the source of the malignancies arise from. And this is a huge problem. This is, there's a couple of cancers that I think have a very significant challenge in that we don't have that line of sight. Certain forms of brain cancer, pancreas cancer, where there is significant challenges in us figuring out, how is it that we can build on significant responses. At the same time, there's a lot of knowledge that's just been accumulated, and we're working very hard to try to convert that knowledge into advances, clinical advances. I think one of the great opportunities in pancreas cancer and other cancers is to attempt to detect these cancers much earlier. And so what happens with pancreas cancer is by the time the majority of pancreas cancers get to the hospital and are detected, they're already advanced and spread. They're not even surgical candidates. And so if we can move that up and actually detect these cancers, understand who's at risk for the developing cancers, and diabetics happen to be one of them, catch those cancers relatively early when they're surgical candidates, then you have a significant increase in the probability of survival, and you can really then use other therapies that might actually significantly extend survival, if not render those individuals cured. And there are many people that have gone through MD Anderson that are more than 10 years out with pancreas cancer that are just fine. Our statistics are a little bit better than what you read about because of our multidisciplinary care and how we bring the teams together to really focus on any specific type of cancer. But this is actually one cancer that I focused a lot of my own career on because of the major challenges and the unmet needs. And I have to say that, we're pivoting, but we don't have that incredible line of sight that we have in, for example, melanoma, where pre-2009, advanced disease, death sentence. Now, with the early stage clinical trials with the immune modulators and so on, it looks like potentially 80% cure. We can't say cure yet because the drugs have not been around long enough, but they're plateauing out at 70% or higher over 3 years. And these individuals generally succumb within 6 to 9. So in pancreas or glioblastoma, brain cancer, we may undergo a very similar inflection point, over the next couple of years, but we haven't gotten that clear signal of activity for any of the approaches that we've had.
Thank you. All right, our last question.
Zafta here. I'm a member of the Advisory Board of Asia Society, and I want to thank these speakers for gracing our stage and allowing us an opportunity to benefit from you. I want to turn the discussion a little bit towards the business side of healthcare. What is Houston doing, or can Houston do, to retain its position on the world stage as a place where people come from all over the world to get treatment? Because now there are other countries, especially in the Asian side, that are into what they call medical business, where patients are flying in and getting treated for different diseases. What can and should Houston do to make sure that those dollars are here so that they can benefit the research that MD Anderson and other hospitals are doing?
Well, I think this one. I think you should take this. But the level of healthcare expertise that exists here is not what you get in medical tourism or whatever. I mean, they're doing basic healthcare, and even that, you still got lots of hurdles there. But I think the sort of work that we just heard about, I don't think there's any other place in the world where they're doing this. So I don't think you need to worry too much, given where MD Anderson is going and the healthcare ecosystem that you've developed around MD Anderson, which actually has pulled up other areas as well. Houston, and I'm talking objectively. I mean, I run a global company. We do business everywhere in the world and all over the United States. And I can tell you that Houston is one of the biggest centers of healthcare there is in the world, led by MD Anderson. It absolutely is. And I don't think that's going away. I think that this is not that easy to copy and catch up. The sorts of work that we're talking about, the projects that we heard, these are decades of expertise and people, cross-functional people, and you can't replicate this that easily.
So first of all, thank you for those really kind words. This is an extraordinary environment. It will continue to be a leader in medicine across, the many institutions that are the Texas Medical Center. But I want to think, and I'll tell you that every single one of those medical tourism places want to have, they come to MD Anderson so that we'll run their oncology component. Why? Because of the expertise that we've generated, just the volumes that we had 1.35 million patient visits last year, did 12 million diagnostic procedures, did over 500,000 diagnostic imaging procedures. At one point, we had more MRI machines than Canada. So, a third of FDA-approved drugs were led by MD Anderson over the last 5 years alone in cancer. So it's clearly a leader and a driver of care, the best care today, innovation to drive new standards of care for tomorrow and so on. But frankly, our responsibility is to help as many people around the world as possible. I'm less concerned about our ability to maintain our financial fitness or our number one status and so on. To whom much is given, much is expected. And our goal as the TMC and MD Anderson and other institutions that are part of it should be to spread our knowledge as broadly as possible and to help as many people as possible and teach as many people as possible all of the great things that we do and we can do to put as much facilitation and wind in their sails so that they can help solve the humanitarian crises that are unfolding in their countries. And I'm very proud of the fact that MD Anderson has 27 sister institutions in 20 countries. And what do? We work with those countries. We've been to China trying to help them with their huge tobacco problem. India with their huge problem with HPV, where that HPV-associated cancers could be cured today because we have a vaccine. All of those things are really critically important, and that's our responsibility. And that's the greatest gift that Houston can give to the world, is to impart our knowledge in a way that improves the quality of life for people around the world. If they can come here, great. This is a great city. It's fantastic. They'll obviously get superlative care here that will not be surpassed anywhere else. You look at the other great institutions like Methodist and St. Luke's and the ability what they can do with cardiac patients, et cetera. Baylor College of Medicine, one of the great medical schools in the world. Those are amazing places, but only a small fraction of suffering people can come here. And so we've got to democratize our ability to care for people around the world.
Thank you.
I think maybe... I thought on that question, I just add a slight spin to it in the sense that although I think in terms of the sophistication of care, there's no question that Houston and the United States in general has a big lead, and I have every expectation that it'll be maintained. I do think, though, that we should look carefully at other countries, I think primarily India, where models of healthcare delivery with a greater degree of efficiency are indeed being developed. And we should look at those with wide open eyes, because a more optimized care is provided. The cost of heart surgery in certain institutions in India is a tenth of what it is, or if not a tenth, maybe a seventh or something like that, of what it is in the United States for the same level of overall output quality. So I think that we can learn from and incorporate efficiency. But I think in terms of the sophistication of learning of medicine, I think we're like way ahead.
I think this will be an interesting subject matter for Asia Society and centers all over the world, and you have begun to kick off a conversation here that I think is very useful. These two men will probably affect our individual lives and those of our families more than almost anyone you will meet, so I hope you will have a chance at lunch to talk to them a bit more. Will you join me in thanking Ronald DePinho and Omar Ishrak?